Yeah, I can hear you.
Oh, great. So, so I will switch to English to introduce our next speaker. We are delighted to have N CASTLEJIN from Groningen with us online to speak about a very important point in the management of ADPKD patients, which is pain and the importance of a multidisciplinary approach. And Nick, thank you very much for being with us. And
Well, thank,
if
yeah,
you
well,
can,
thanks for the introduction. Can you hear me loud and clearly?
yes, perfect.
Oh, perfect. So yeah, the traveling to Brest is for me like a 1 day traveling from Paris to Brest with two flights or with the TGV, and that's a little bit like 18 hours one way. So I decided to do it like this way. And I would like to tell you a little bit more about pain in ADPKD. Have no disclosures, and I'm from Groningen. It's the northern part of Holland, and the University Medical Center in Groningen is an expertise center in healthy aging, and we do all transplantations in all kinds of organs in Holland, but we also are an expertise center for polycystic kidney disease. Pain in EDPKD, it's quite common. Around 60% of all patients experience pain, and it's assumed to be related to cyst number or size, also with later in life and also with the severity of disease. We see that it is more common in women compared to men, and sometimes when pain is chronic, it's difficult to treat. Medications are options, but also we see that there are lots of patients need invasive therapy. We can differ in two main forms, like acute, sudden onset, limited duration, and when it exists for more than 6 weeks, we can call it chronic. Of course, it also could be non-ADPKD related, and when it's ADPKD related, it can be caused by distension of the renal capsule, but also because of compression of surrounding tissue. We also see that patients with acute pain due to sensitization can develop chronic pain. When we have it about acute pain in ADPKD, three main causes like cyst bleeding or a cyst rupture. Acute pain, patients have the prevalence to lay still. Sometimes patients can develop fever, and by drinking a lot of water, we see that it's most of the time with painkillers, it's over. Kidney stones and cyst infections. Cyst infections need antibiotics, and kidney stones, in case of obstructive stones, need more like treatment of stones, like also in non-ADPKD patients. Management, as mentioned before, painkillers, paracetamol, steroids can give, but are contraindicated in patients with a very low kidney function, and opioids. We can differentiate it between low and high opioids, like tramadol are the low volumes, but we advised to only use strong opioids like oxycodone or morphine. And as mentioned before, antibiotics can be given in patients with a UTI. Instead of symptomatic treatment, we can also treat underlying disease. Somatostatin analogs can give in patients with severe polycystic liver disease, in patients with chronic liver disease, in patients with high volume kidney disease. There is no indication to give somatostatin analogs. And also we know about the study, the 4 study from tolvaptan, that tolvaptan could be given in patients with acute pain events. With a post hoc analysis of the study, the TEMPO trial, the study showed that that tolvaptan could ameliorate disease progression in ADPKD patients. And in a post hoc analysis of this study, we also see that tolvaptan could reduce with a relative reduction of 36% acute renal pain events. And if we have it about the underlying mechanism, we do not see that in these patients with on tolvaptan, that these patients have the growth of the kidneys is more reduced, but we see that in patients with the use of tolvaptan, that there are less urinary tract infections, less stone formation, less cyst bleeding. So the underlying cause of acute pain is reduced, resulting that these patients experience less pain in all pain dimensions, like also from hospitalization, like invasive therapies, but also in the use of medication. So I would like to tell you a little bit more about chronic pain, because acute pain is often could be mentioned and could be treated quite well, and chronic pain is a little bit different and also be a little bit more difficult to treat. And we know that for these patients, an effective protocol was not available, and we try to develop one, and also to preserve in these patients kidney function, because we treat patients with the known that renal function declines. Eligible patients in our protocol are patients that experience pain for more than 3 months with a visual analog scale score from 50 out of 100. And the chronic pain should be incapacitating, influencing social life, or leading to the inability to work. And all these patients were opioids dependent. All patients were screened by or a nephrologist or a urologist, but also by a pain specialist. After that, standard measurements were done, like blood, renal function, check of urine, but also a 24-hour urine check. Imaging of the kidneys and liver were made, and also renography. And after screening, all patients were discussed multidisciplinary to distinguish which treatment were the most optimized treatment for that patient with the most effect on pain. So patients were referred from all over the country, but also from Belgium and Germany. And this is a patient map from 2020. It's with more than 100 patients, and at the moment, 50 more patients are in our protocol. So patients are all over the country, but also some from Belgium and Germany. And about our protocol, we made a step-up protocol. So first of all, we have to check out whether the pain is ADPKD related or not. And when the patient experience not ADPKD related pain, standard treatment as appropriate is given. First step in treatment are non-invasive, non-pharmacological options like behavior modification, ice and heat pads, or physiotherapy. And if in case of these options are not have enough effect, pharmacological options like paracetamol and opioids could be given. And I would like to tell you a little bit more about the minimal invasive therapies. And in case of dominant cyst aspiration or fenestration, you can try it. So over here you can see 2 MRIs from a 48-year-old woman with a great cyst in the liver for more than 1.5 liters, and we did an aspiration, and we see a great effect on pain. The patient experienced a visual analog scale of 80 out of 100, and after aspiration, the patient pain score dropped to 20 out of 100. We know, of course, that after aspiration, cyst fluid can recur. And when we performed an ultrasound and we see this cyst was in the same form and the same volume, we could perform an robot-assisted laparoscopic fenestration. Also good effect on pain. The other point of our protocol are nerve blocks. And for nerve blocks, you have to know a little bit more about the sensory nerve ways from the kidneys and the liver. And I would like to give you the pointer is working. Kidneys and organs in your abdomen, only the capsule from the liver or the kidneys is innervated. So the inside of your kidneys didn't feel anything. So if you have the experience of kidney pain, it is caused by your renal capsule. Because we know in ADPKD, the kidneys and liver can be growth extensively, could be caused that the patient experience loin pain, but due to compression of the liver or due to compression of the kidneys on the spleen. The pain is caused by compression of the surrounding tissues, or is caused by distension of the renal capsule. And we know that both kinds of pains travel by different routes. As you can see on this figure, you can see that when the pain is caused by the renal capsule, pain travels via the renal artery, the arterial-renal plexus, the less splenic nerves to the sympathetic trunk. And when the signal is reaching your brain, then the signal is modulated by an experienced pain. So if you can interrupt this pathway, you can modulate pain, and you can also, by interrupting the signal, you can also resulting that patients experience less pain. So we have to distinguish from which route pain travels. So is this the route from the arterial-renal plexus, or is this the route from the celiac plexus? And an option to perform a diagnostic tool is a celiac plexus block. What you can do is by injecting local anesthetics around the celiac plexus to interrupt the celiac plexus travel path. So how are you doing this? Patient is on a prone position. Imaging was performed before, and because of the enlarged kidneys or liver, sometimes the celiac plexus could be dislocated. So we know the exact location from the celiac plexus by MRI. With radiofrequency guidance, we can inject 10 or 20 cc lidocaine, and we can wait for the effect of this block on pain experience. The effective of this block is effective in 2/3 of the patients, with temporary effect in 50%, but surprising also a long-lasting effect in 50%. And if pain recurs, we can do a long-term block with radiofrequency ablation. And because this diagnostic block, we know lidocaine is bringing, and the effect of lidocaine is 16 hours, but if it recurs, we can do with radiofrequency ablation, burning the sensory pathway. Effectively, initially in 85%, and sometimes pain recurs, and this procedure can be repeated. So this is just a local block with local anesthetics for the celiac plexus, and the splenic nerves are lying over here, and it's a very small radiofrequency ablation block. It's over like here. In case this route did not result to effective pain relief, we assume that it is reached by the arterial-renal plexus. This plexus could not be reached by a needle, and we performed, first of all, catheter-based renal denervation. So by interrupting the sensory nerves around the renal artery, we could interrupt the pathway from the arterial-renal plexus with a catheter base that's placed by the iliac artery. But this technique is at the moment less available in the Netherlands because of the disappointing results in therapeutic resistant hypertension. So an alternative of this block is performing as a sympathetic trunk block. So you can also perform a block over here, like by performing a sympathetic trunk block at the level of thoracic 12. You can also result with the same effect block if you perform like a renal artery block. That's just my information about the blocks. And in case of a block didn't work, or the patient is already renal replacement therapy dependent, also more invasive therapeutic options are indicated, like nephrectomy or even a liver transplantation. So this is one of our patients after and before nephrectomy. And as you can see, the complete kidney is around cysts. It's a safe procedure. You can also do it open or by a laparoscopic procedure. And both surgical techniques has no effect on effective pain relief. Other thing is do we have to perform this surgery before or after transplantation? Sometimes it's said that after transplantation, it may be a risk for the transplantation kidney. That's not the case. Could be safely performed before and also after transplantation. No effect on patient survival, but also no effect on graft survival. The other thing is, do we have to perform an nephrectomy before transplantation? We did a large study in patients with or without nephrectomy before transplantation. And as you can see on this quality of life study, you see that quality of life in patients that underwent nephrectomy before transplantation, quality of life is less compared to patients that not needed a nephrectomy. And after nephrectomy and transplantation, patients experienced the same level of quality of life. So instead of low quality of life and large kidneys, and there's an indication for nephrectomy, also quality of life could be an indication for nephrectomy in patients with ADPKD. Results from our protocol. I do not have the update from our protocol right now, but hopefully next year. But 2 years ago, 101 patients were treated in our clinic, underwent cyst aspirations. Majority of patients, 64, underwent a diagnostic block with the celiac nerves. 20 of these long-lasting block of the splenic nerves, 25 multiple blocks, 5 blocking of the nerves of the kidney by catheter-based renal denervation or sympathetic trunk block. Only in 4 of these 101 patients, nephrectomy was performed initially. As you can see overall in the spaghetti plot, the pain score dropped. And also, as you can see, it's not only a short-term effect, but also a long-term effect. Even like the pain score, also the use of opioids, also the non-use of non-opioids is dropped. You can see also that the daily dose of opioids is dropped and still dropped after long term. So it's like a double effect. From all these 101 patients, 51 patients needed additional treatment, 45 long-term block, 5 patients catheter-based renal denervation, and 1 patient also needed a diagnostic block after hepatectomy. And in some patients, upscaling was needed, like cyst aspiration needed cyst fenestration, and some patients also needed a nephrectomy or hepatectomy after a nerve block. Overall, results from pain and the use of stopping or reduction daily opioid use. Short-term effect, 80% of patients can stop daily use of opioids, and also PAS score dropped from 60 out of 100 to 20 out of 100. But also in long-term effect, like with a median follow-up of 40.5 years, you still see that 35% of all patients could stop or have stopped their daily use of opioids. Many patients reduce their daily use of opioids, but also the FAST score still is dropped from 60 to a 40. Well, some conclusions from our protocol. It's lots of patients suffer from pain. Could be acute, could also be chronic. Most of the time, chronic pain is often difficult to treat. It's related to sensitization or by distension of the renal capsule or by compression of surrounding tissue. Nerve blocks can help and achieve adequate pain, and also avoid or delay the need for nephrectomy. Some notes, some cautionary notes. Promising results, but please note, as you can see in our protocol, there are lots of treatment possibilities, and also you can see that in 27% of our referred patients, other treatment options were performed. No treatment, symptomatic treatment, cyst aspiration, or nephrectomy. Blocking pain is could also be dangerous because by pain is a signal for a danger like a cyst infection or some other problems in the abdomen, and by modulating pain, it could also result to a patient or doctor delay. Other thing is because of the enlarged kidneys and liver, blocks may be difficult because of an altered anatomic situation. And therefore, we advise to do it only in centers with expertise with these blocks. The other thing is our protocol seems to be effective, but could these results also mean that we can lose our criteria? So maybe we can also perform nerve blocks in pain with less pain, but also maybe we can also perform this protocol in other patients, like non-ADPKD patients. And as you can see in some new data from our center, we also performed this block now in non-ADPKD patients, and also we can see in non-ADPKD patients, our multidisciplinary approach results to achieve long-lasting pain. And as you can see in these patients with chronic loin pain, also with medium follow-up time of 4 years, there's a drop in VAS score, there's a drop in daily use of non-opioids, and also a drop in opioids. So promising, and hopefully we can do some more follow-up in other patient categories, whether this protocol could achieve pain relief. Well, thanks for your attention. Are there any questions?
Okay, so thank you very much, Nick. And sorry, there were people, everybody was clapping, but you didn't hear that because we were not able to. So
you can repeat it.
So thank you very much. There might be questions in the room. I have a question. You were mentioning a concern that some patients with efficient block might subsequently have delayed symptoms of something going on, and so did you really have those cases? I would think about maybe renal cyst infection or liver cyst infection being diagnosed a bit later because patients did not feel the pain?
Yeah, we have a couple of cases. We have a couple of cases, and we mentioned before this use of blocks that patients could experience fever, could experience stranguria, mixing problems, like other things, but that pain is a late symptom. And we know that pain routes are not just one line. It's a complex network of sensory nerves. So we see that in patients with a cyst infection, normally they develop pain in 1 or 2 days. Then patients develop pain in 4 or 5 days. But fever and problems with micturition are first-line symptoms.
Yes, thank you. I think it's a very nice example of multidisciplinary and stepwise approach, and it sets a very good example for other expertise centers in the world. So thank you very much. Are there any questions? Yes.
Great talk. Thanks a lot, sir. It's not about pain, but have you any evidence that the clinical innervation or artery innervation may impact cyst formation or cyst growth?
Sorry, can you repeat the question?
Yes. Is there any evidence, or do you have seen whether or not the innervation of the renal artery could affect cyst growth? Have you checked whether or not the kidney was still growing after the innervation? Or... Yeah,
we checked it, but the numbers are quite low, and so in our small group we don't see any results from renal denervation on cyst growth, and not also on renal function decline.
Another question?